So, hello everyone. My name is Anthony Moreno. I am an exercise science major going into my senior year here at Lewis. This summer, I had the pleasure of working alongside Dr. Victoria Reynolds, who is part of the speech and language pathology program. And the title of our work is The Influence of Premature Birth on Laryngeal Development for Phonation. So, there was a lot in that introduction, that title. So, let's go ahead and break down some key terms that I believe are most that'll be good for you all to comprehend throughout this presentation. So the first term is phonation. Phonation, simply put, is the production or utterance of sounds as produced by the vocal folds. Simply put, it's a result of aerodynamic forces that causes those vocal folds to vibrate and produce what we know as quote unquote voice or sounds. Next, we have dysphonia. Dysphonia, once again, simply put, it's the difficulty in speaking due to a physical disorder of the larynx or part of the larynx. There are different types of dysphonia, some more severe, some mild, different causes. However, the most common is caused by the swelling of those vocal folds due to overuse or infection. And if any of you have ever had a cold and lost your voice for a bit, then technically you had dysphonia. So there's that. Some symptoms of dysphonia are voices that sound rough, hoarse, gravelly, or raspy. On the other end, there are voices that can sound weak, breathy, airy, almost like a whisper. And then in addition, there are voices that sound strained, pressed, squeezed, tight, or tense. So as you can see, there's an array of symptoms, and there are different cases of dysphonia. So luckily, Dr. Reynolds was kind enough to allow me to show some real world examples of patients she had in the past. So this first example is of a patient who had a strained voice. So let's go ahead and take a listen at this.
The blue spot is on the key again.
The blue spot is on the key again.
How hard did he hit him?
How hard did he hit him?
We were away a year ago.
We were away a year ago.
Okay, so as you can hear there, voice a little strained. At first, it sounds like his words are coming off normally, but eventually his voice gets cut off and strained, and just doesn't allow him to speak in the manner in which he would like to. So the next example is an example of a patient who has a rough or breathy voice. So let's listen to that.
The blue spot is on the key again. How hard did he hit him? We were away a year ago. We eat eggs every Easter. My mama makes lemon muffins. Peter will keep at the peak.
So obviously you can hear that's actually a female patient, a female child. Her voice was rough, breathy, and almost like a whisper, not allowing her to have that full voice that either you and I can demonstrate. Sorry about that. Next key term is premature birth, which I'm sure most of us are aware of, but just to recap, it's an early birth that takes place 3 or more weeks before the estimated due date, which is 40 weeks. There can be causes of premature birth, but a lot of them are spontaneous. That's the word. Sorry, spontaneous, and they happen unprovoked. In our case, it's worth noting that the earlier the birth, the more chances of complicated medical conditions that lead to medical intervention. So one of the most common interventions that must take place is intubation, because premature babies oftentimes, or most times actually, have trouble breathing. So they go through mechanical ventilation, which in itself requires a lot of prolonged intubation, which can lead to physical mild trauma to severe complications such as vocal fold paralysis, which in turn would lead to dysphonia. The next intervention is surgical intervention with patients who have PDA, which is patent ductus arteriosus. And PDA is a persistent opening between two major blood vessels leading from the heart. And this opening is actually normal in babies when they are in the womb. However, when they are born, this opening should close. And when it does not close, it is considered PDA. This results in oxygen-rich blood circulating back into the lungs, which leads to a domino effects of different complications. This is resolved through PDA ligation, which is the intervention, the surgery that takes place where a doctor makes an incision on the side of the child's chest and puts a long catheter or tube, which can lead to other complications. And in our case, this is important to note because the laryngeal nerve sits right here, very close to the aorta, next to where that opening is. So just due to proximity, that surgery oftentimes affects the vocal folds and affects the child's eventually ability to speak, leading to dysphonia. Now, these interventions have been known to lead to dysphonia because of the close proximity of the vocal folds. However, we have been seeing cases in which those premature babies who are not intubated or who do not go through PDA ligation are still having dysphonic complications. And we kind of ask ourselves why this is happening. As we can see here, these are just some numbers from Dr. Reynolds' work. While she was getting her PhD, she had the chance to work with both intubated, non-intubated children, both preterm and term-born children. And on the top, we can see that 109 out of 178 preterm babies who were intubated suffered dysphonia or had dysphonic complications, which, like I said, it's obvious. We've been knowing these interventions cause dysphonia. However, on the bottom, as we can see, 17 out of 40, which granted is not the hugest, the largest sample size. However, 17 out of those 40 were known to have complications with dysphonia. So we ask ourselves why this is happening. And this leads us to our work that we've been doing over the summer. So our aims of this study, obviously we are unable to work with human larynges because humans kind of need them to talk and to breathe. So the aims of this study is to determine whether ovine larynges, ovine pertaining to sheep or lamb, whether they are measurable, feasible, and reliable to be able to compare to human larynges. We are also looking to demonstrate the differences based on gestational age and ventilations provided. Getting into our specimen collection, we were able to collect 11 very preterm, 4 extremely preterm, and 2 term-born lambs, which were excised following euthanasia. We went ahead and all the extraneous tissue was removed and specimens were sectioned off so we could be able to measure both internal and external measurements, which we will get into shortly. For morphometric measurements, we went ahead. These are the tools we used. This is the digital caliper that we used to measure the larynxes. And then we had a light source because the larynges were very, very light. They're delicate, they were small, so we needed extra light to be able to distinguish between the different sections of those vocal folds. So here we can see the external measurements that we went ahead and took. We took 2 measurements for the width of the thyroid cartilage, and the first one was the anterior commissure, which is right here, this little prominence. That measurement to the posterior margin of the blade, which is right here, this lateral aspect of the thyroid. And then in addition, we took the thyroid notch, which is a little hard to see, but it's the top of this triangle to that posterior margin. So those 2 measurements were used to determine the width of the cartilage, both on the left and the right side. In addition, we went ahead and measured the thyroid notch right here again to the anterior commissure, the little prominence right there. And then we also did the anterior commissure, that point again to the inferior thyroid border. A little hard to see here, but it's the bottom of the thyroid. And then lastly, we did the anterior gap, which is a space between the cricoid cartilage and the thyroid cartilage. For internal measurements, we went ahead and took the length of the membranous portion and the cartilaginous portion of the vocal folds. We went ahead and got measurements of the total length, the width, the thickness of the vocal folds, and also the height of the ventricular space. And here's a little picture of all the, what most of them look like, give or take. So you can see very small, very delicate, little hard to distinguish the different structures just because of the discoloration, but that's what we were working with here. Now getting into results, for time's sake, and I would imagine none of you have spare lamb larynges sitting at home that you measure, but if you do, just shoot me a text and maybe we can compare numbers, but I'll go ahead and just run through the numbers real quick. We have some numbers of the term-born, external measurements for the term-born, very preterm, and the extremely preterm measurements. And then for internal measurements, you'll see that we have term-born measurements, very preterm, but we actually didn't, we weren't able to get any internal measurements for the extremely preterm, and that's because when we were measuring the term-born internal measurements, we were noticing that the digital calipers that we were using were actually very sharp, a little bit too invasive to measure, and it was leading to destruction of the mucosa of the vocal folds. And we didn't want to do this because eventually we would like to do some histological examinations of these specimens. So we decided that these calipers were just a little bit too rough for these very fragile, very squishy, soft specimens. So we decided not to take those. Okay, now getting into the age-related hypothesis testing. For external measurements, we noticed that the more so the larger measurements, we were seeing a difference in measurements between all categories being the different ages. We're seeing differences in those measurements for internal measurements. Most of the measurements we were seeing what we were expecting. There's a difference in measurements between very preterm, extremely preterm, and term-born larynges. For reliability, most of the measurements had moderate to significant reliability, which is extremely important for work like this when we want to measure the feasibility, the reliability of these specimens compared to human larynxes, because we just want to ensure that whoever measures these specimens, it's going to be reliable and accurate all the way through. For discussion, there is an age-related difference in these findings in the larger measurements. It could be an artifact of our small sample size, as we only had 17 samples. However, we are the only ones that are working with ovine larynges to be able to compare to human larynges, and most of our data is showing that most of our data supports this age-related hypothesis testing that the measurements are actually different between across all categories. It is worth noting that there was a little bit of ambiguity in some of the smaller measurements. For an example, here, this is just a little stock image of a human larynx. As you can see here, it's flat. Here's the notch, and here is the middle of that thyroid. It's very flat, there's no prominence, but when seeing what we were working with, where it was flat in the human larynx, we see this little prominence right here. And not the problem, but the thing with that is when measuring, it's a little bit subjective to the measure to distinguish where they think that structure is. So there's a little bit of ambiguity with that measurement. For future directions, ideally, like I said, we would like to aim to have a larger sample size, maybe a little bit more than 17, just to ensure that feasibility, that reliability. Our plans are to make these histological examinations. They're in the works, not done yet, but they're in the works. And also, we would like to find a way to be able to measure these internal measurements of the extremely preterm larynxes without just disrupting the mucosa, so we can also do these examinations of the histological examinations. So to conclude, we do have 3 sets of measurements for term-born, very preterm, and extremely preterm larynges. According to our data, the age-related hypothesis holds for the most part. This mammalian model looks promising in terms of morphometrics. And we, as a team, hypothesize that these histological findings will inform aspects of human laryngeal development going forward with future studies. I'd like to acknowledge all the financial supporters, all the supporters of the SURE program, Dr. James Gerard, Russ and Don Smith, the Aileen S. Andrew Foundation, Dr. Katie Hanley, Dr. David Livingston, Dr. Christopher Sint, and the Office of the Provost. And last but not least, I'd like to acknowledge the rest of the team members who were able to make this work possible. Thank you all.